All right, today we're diving deep into the ICU to get our heads around a machine that can literally be the difference between life and death, the mechanical ventilator. Now, I know it's complex, it can seem kind of intimidating, but we're going to break it all down step by step to see how it really works.
So let's just start with a really big question. When a person is at their absolute most vulnerable, when their body just can't perform its most basic, most essential function, breathing, what is the ultimate form of life support?
Well, the answer is about as direct as it gets. It's a machine that literally breathes for you, taking over the most fundamental job of just staying alive. And that is the whole idea behind mechanical ventilation. It's this critical intervention for patients whose own respiratory system has failed. It could be from a serious illness, a major injury, or even because they're under sedation for surgery.
And here's something that's really crucial to understand. Starting ventilation isn't some last-ditch Hail Mary effort. The decision is actually made pretty early on to support the patient before they hit a total crisis point. It's about preventing them from getting worse and giving their body a real chance to heal. Okay, so once a patient is on a ventilator, the very first major decision a clinician has to make comes down to one of two core philosophies for how to deliver a breath. And this choice, it's the foundation for everything that comes next.
So here's the core trade-off. With volume control, you are absolutely guaranteeing the amount of air that goes in. This makes sure the patient is getting enough oxygen. But the pressure it takes to push that volume in can change. Now, with pressure control, you set a strict safety limit on the pressure to protect the lungs, but the amount of air the patient actually gets can be different with every breath. It is this constant, delicate balancing act between ventilation and protection. All right, so after they've chosen that basic philosophy, are we focusing on volume or on pressure? The next step is to pick a specific mode. You can think of it like a program that tells the machine exactly how it's going to interact with the patient. Let's look at the main options on the menu. So the most common place to start is with a full support mode, and that's usually assist control, or AC. In this mode, it doesn't matter if the machine triggers the breath or the patient tries to. The ventilator gives a full machine-powered breath every single time. It's doing all the heavy lifting for the sickest patients. But as the patient starts to get better, the goal is always to get them breathing on their own again, right? And that's where these weaning modes come in. Modes like SIMV and pressure support start to hand the control back to the patient. They make the patient do more of the work, rebuilding that respiratory muscle strength. You can almost think of it like physical therapy, but for the lungs.
Okay, so a mode is chosen, but we are far from done. That's just the beginning. Now the clinician has to get in there and precisely program the ventilator, setting all the dials to tailor every single breath to that one specific patient. And this number right here, this just shows you how incredibly precise this all has to be. The size of each breath, that's the tidal volume, it isn't a guess. It is meticulously calculated based on the patient's predicted body weight. See, if you give a breath that's too big, you can actually injure the lungs. So the goal is always to use the smallest, gentlest breath that gets the job done. Now, this number, this is the big one. This is the absolute do not cross line. This is a pressure limit, the plateau pressure, of 30 or less. It represents the pressure inside the tiniest little air sacs in the lungs, and going above this dramatically increases the risk of what's called ventilator-associated lung injury. It's a non-negotiable safety rail. You can think of this table as the ventilator's main dashboard. Clinicians set the tidal volume, the respiratory rate, the percentage of oxygen, and something called PEEP. PEEP is just a little bit of constant pressure that helps keep those tiny air sacs from collapsing between breaths. Every single one of these settings has to be perfectly balanced to support the patient without causing any harm.
So, you have the mode, you have the settings. How does this all come together for a real patient? Well, it's not just about picking a mode and twisting some dials. It's about creating a cohesive strategy that's based on what's actually wrong with the patient.
And here is a perfect example, the strategy for ARDS, which is a really severe form of lung injury. The whole goal here is lung protection. Now, this is where it gets really interesting. Clinicians will intentionally use tiny breaths, and sometimes even let the patient's carbon dioxide level rise higher than normal. It's a strategy called permissive hypercapnia. I know it sounds totally counterintuitive, but it's done for one critical reason: to protect those fragile, injured lungs from any more damage from the machine itself. So when you step back, you can really see the whole thought process, right? It's these logical steps. First, you identify the problem. Is it ARDS, like we just talked about, or something else like COPD?
Then you choose the right mode and the right strategy, you put in your initial settings, and then, and this is the most critical part, you monitor constantly and you adjust. So for that COPD patient, for example, the main worry might be giving them enough time to breathe out, so that IE ratio becomes the focus. Everything, blood tests, vital signs, just how the patient looks, it all feeds back into fine-tuning that machine.
And that really gets to the heart of it. This quote says it all. You do not just set it and forget it. Ventilation is this incredibly dynamic, minute-to-minute process. It's a constant dialogue between the clinician, the patient, and the machine, all working to perfectly match the support to what the patient needs at that exact moment. So, in the end, yeah, the ventilator is a machine of pure numbers and physics. But applying it correctly, that is so much more. It's this profound mix of hard science and incredible clinical judgment. It really is the art of medicine at its most intense. And that leaves us with the huge central question that critical care teams have to grapple with every single day. Mechanical ventilation is an unbelievably powerful tool that saves lives, but that power comes with its own risks. So the challenge is always this incredibly delicate balance. How do you provide that life-sustaining support while at the same time protecting the very organs you're fighting so hard to save?